Thank you. That was very kind. I am very appreciative of the invitation and the ability to be able to come to Korea. My hosts have been wonderful, and thank you for the dinner last night, and thank you for the organizing committee for all the work they've done. I'm going to be talking about one of my favorite topics, which is navigating the clinical challenges of blunt liver and blunt spleen injury. And I'd like to start with a case, and this is a 15-year-old boy who was holding on to the door handle of a car when the driver pulled away, and his hand was caught in the handle, and he was dragged under the car and run over. He shows up at my emergency department with a heart rate of 144. He's got a blood pressure, his systolic blood pressure is 130, and his abdomen is mildly distended. He's got some right upper quadrant pain to palpation. He has abrasions over his entire body, but especially over the right upper quadrant of his abdomen. He's pale, and he's got a delayed capillary refill time. And he's already received some saline en route. His hemoglobin is 10.1 on arrival. His FAST exam of his abdomen is positive for fluid in the abdomen. He gets a CT scan of his head and neck that are negative, and his chest imaging shows a pulmonary contusion and some air in the mediastinum. The CT of the abdomen shows a liver injury, a pancreatic neck contusion, and adrenal hematoma. I'll walk you through some of those studies. So here is the chest CT. He's got pretty significant pulmonary bruising there. For those of you who look at CTs all the time, you'll recognize this as a pretty impressive liver injury. As we go through some of the cuts, we see some blush on the CT, and we see some free fluid in the pelvis without contrast. So the question is, can this patient be managed without surgery? And really, that's the defining question in pediatric blunt organ injury, which is when do we need to say we can no longer manage this patient without taking them to the operating room? So I'll take you through some of my research over the last 15 years. We're going to examine the top clinical challenges in pediatric blunt trauma. We'll look at outcomes in a study that I just published in the Journal of Pediatric Surgery of 1,000 children with blunt liver and spleen injuries. We'll look at why there are differences in splenectomy rates between various centers in the United States, and then where we go from here. So this was an article that I published almost 9 years ago now on non-operative management, and this was developed with 5 other colleagues and in what was at the time the Atomic Network. So that network is now the A+ Pediatric Trauma Research Network. And what we did was we looked to see if we could formulate questions that needed to be answered and then answer those questions based on existing literature. And we identified 600 articles, and 142 of those articles were relevant to the questions that we were trying to answer. And those articles encompassed about 69,000 patients. So there had already been a reasonable body of work out there that was largely being ignored by the trauma community. And the reason that we had so many patients is that we had a fair amount of retrospective studies, and we had a lot of database studies, about 45,000 patients in database studies. And so there was at least a foundation at which we could start making a guideline. The guideline that we made looked like this, and this was the original guideline that we published in 2015, and I'll walk you through that. But I'll tell you that guideline has now been replaced by this more current guideline, which is a little bit easier to follow and has a little bit more science to it than our original guideline did. This is the same guideline translated by Dr. Kyung for me. So it's available in Korean if you need it in Korean. Basically, we start with the question of whether or not the surgeon thinks that the patient has recently bled or is currently bleeding. And that's a really important distinction, because when a patient arrives, all you know is that they're in shock, and we'll talk about that more in a minute. If the patient we don't think the patient's bleeding, then we just admit the patient to a non-ICU ward. We check their vital signs, and then if their vital signs stay good, they can go home in 18 hours. If their vital signs are not good, we recheck their hemoglobin. If their hemoglobin is less than 7.0, we give them a blood transfusion. And if their hemoglobin fails to stabilize after that blood transfusion, they cannot stay in the stable arm. They have to get admitted to the intensive care unit and transferred into the unstable arm. The unstable arm patients, they get a bolus of 20 mils per kilo of crystalloid. Now, if they got it in the field, they don't get a second bolus of crystalloid. If they have no response to that crystalloid, they then get blood. And this, I know that you are looking at the updated ATLS. I will tell you that when we wrote this in 2011 and published it in 2015, the concept that you went from 20 mils per kilo of crystalloid to blood was very radical, because at the time, ATLS said give crystalloid, give another bolus of crystalloid, give a third bolus of crystalloid. And we basically said that's not the right thing to do. We started giving blood after they got the first bolus of crystalloid. If they don't have a response to the blood transfusion, or if they get hypotensive a second time, that patient has failed non-operative management. So if you give them blood and they are transient responders, that patient needs to go to the operating room. If they have a sustained response, then that patient can be admitted to the ICU and we check their serial hemoglobins. Those are the patients who need serial hemoglobin checks. I will tell you that you'll notice in the other pathway, they're not getting serial hemoglobins, they're getting vital sign checks. In this pathway, the unstable pathway, they get their hemoglobins checked, and if they are stable for 18 hours, they can leave the unstable pathway and go to the stable pathway. If their hemoglobin is less than 7.0, they get transfused packed red blood cells. If they get more than 40 mils per kilogram or 4 units of packed red blood cells, then they have failed the algorithm. It doesn't mean they have to have surgery. It just means that the algorithm can no longer direct how that patient should be cared for. So that was 9 years ago. So now we actually have some data. So one of the questions that we started the algorithm with was, does the surgeon suspect that they're bleeding? And one of the things we needed to know whether or not we can base the management on their hemodynamic status, because that's really what the surgeon's using to make that determination, or whether or not we should be managing these patients based on their CT scan. And there actually were about 3 studies consisting of maybe about 250 patients or so, where they said, yeah, actually it's their hemodynamic status that matters, not their grade of injury, that it really determines how we should be managing that patient. This is the study that came out this month in the Journal of Pediatric Surgery, where we looked at 1,029 patients. About 1,000 of them were prospectively enrolled, and then we had to go back and retrospectively enroll 27 other patients who were too sick to have a CT scan. So how did we do? How did we do at determining which patients were bleeding and which ones weren't? Well, first of all, you have to realize that the vast majority of patients were assigned to the not bleeding side of the algorithm. So 70% of the patients, when they come to the emergency room with a liver or spleen injury, are actually assigned that they're not bleeding or they haven't bled significantly from a clinical standpoint. And then about a third of the patients, or 31%, are in this unstable arm. When we look at the highest grade of injury by stability, because these are liver injuries and spleen injuries, you'll see that the stable patients are definitely skewed. The blue bars are skewed towards the left, so they do tend to be the less severe injuries, whereas you'll see that the unstable patients are more likely to be in this category, which is the unstable patients are more likely to have a higher grade of injury. So there is a correlation. What we sought to do was to define who could be managed non-operatively by figuring out who had to have surgery. And so really that's what this research was about, was who is it that cannot be managed non-operatively. And this provided a framework, and then we took that algorithm and we put it into practice at 10 level 1 pediatric trauma centers and studied them for 10 years. And so the question is, how did the algorithm perform? We knew how it was developed, but now we're actually going to put it into clinical use. So we took all children under 18 years of age and we enrolled that 1,000 patients. And the first thing that we had to do was decide, what do we mean by stable? And there's no single measure that the surgeons were using to define what they thought was clinically significant bleeding or how they did it. And so it remains a clinical decision, but it turns out that there are a lot of factors that you can put down on paper and say, this is what we look for. This is what we need to be looking for in order to make that first decision. So hypotension. The problem with hypotension is that it's a late sign, and you can't rely on hypotension in children alone as an indicator of shock. Tachycardia is also a very early sign of shock, but it's too sensitive. So a lot of patients will come in with an elevated heart rate for other reasons like pain. Capillary refill time, though, is a pretty reliable indicator. And so if they have a capillary refill time less than 2 seconds, that's a really good indication that they are underperfusing their bodies. Shock index, which we had an excellent lecture on earlier from the in postpartum hemorrhage, is very important. But the problem with shock index in children is that they have a higher baseline heart rate. And so there is a SIPA, which is shock index pediatric adjusted. And what we say is that younger kids can have a shock index of about 1.4 before you start to worry that they're in shock. School-age kids, 1.2, and then older kids, it's the 1.0 that we use in the adult population. So shock index, and we studied this later, and I'll talk about this in a minute, is actually a pretty reasonable indicator for who is not in shock. Pallor, so if the patients have pale lips or pale fingernail beds, that's a strong indication they have inadequate perfusion. And these clinical signs are actually really useful, as is a cold or mottled extremity. So if you put your hand on the patient's ankle and it's cold, that patient is underperfusing and is clinically in shock. All right, so how did our surgeons do? Well, our under triage rate was 1%, meaning that in this 1,000 patients, 11 patients were under triaged. And when we look at what patients were under triage, you'll see that there are a few low-grade injuries here. And a lot of times the reason that they're under triage is because they have a more severe injury that's not a liver injury or a spleen injury that really resulted in the bleeding. So some of the patients had intestinal bleeding and they happen to have a liver injury, or they had a pancreatic transection and they happen to have a spleen injury. The over-triage patients, we had about a 3% over-triage rates, patients who went to the intensive care unit and then didn't really need to be in the intensive care unit. So overall, these clinical factors do very well at defining who is stable and who is unstable. So one of the things that became very apparent as we started the study was that there were some patients who were transient responders, that there were some patients who responded initially to blood and stabilized, and then while they're in the CT scanner became unstable again. And the algorithm initially did not specify that those patients failed. We knew that 40 mils per kilo was a failure point, but it turns out we had to add this other failure point, which is being a transient responder. Those patients fail non-operative management. And we actually had one patient who had a severe injury, and this is in the article that's coming out this month. When we started the study, that patient got blood, made it to the CT scanner, got hypotensive again. They had injuries, they had a head injury, a pelvic bleeding, and they had intra-abdominal bleeding. And the decision was made to continue non-operative management. And because they hadn't reached 40 mils per kilo yet. And we decided that was actually not what we had intended. And so we added that transient responders now really fail non-operative management. So if a patient comes in shock, should that patient just go straight to the operating room? Like, should we say, well, this kid is in shock, there's no chance that they should have non-operative management because they're in shock. But it turns out that a lot of patients, a lot of children who come in are in shock and they get transfused. About 18% of these patients are transfused and still have non-operative management. And the surgery without giving them a blood transfusion we were concerned that was contributing to non-operative management failure. And we'll talk about that in a minute. But there wasn't any direct data to support that, but we still put it in the algorithm that you couldn't fail non-operative management until you got blood. And it turns out that actually was the right thing to do. We didn't have any data on permissive hypotension in kids. I think it's a bad idea, but I don't have any data on that, and no one has any data for it either. So, the other thing was that there wasn't data to show that if you gave them blood that you were less likely to, that you were more likely to save their spleen or their liver. What we found out over time was that the only thing that you know about a child who arrives in shock due to abdominal trauma is that they have bled. You don't know that they're still bleeding. And that was, I think, what we thought was the big difference between pediatric patients and adult patients. Spoiler alert, I will tell you later that it may not just be limited to kids. So when we looked at the differences between our centers in the United States, between adult trauma centers taking care of kids and pediatric trauma centers taking care of kids, we found that the splenectomy rate was much higher at the adult centers. And the adult centers said, well, we take care of sicker patients, we do this, we do that. They said, that's why we take out more spleens. And this led to another study. And the good news, this was a database study, so the Kids National Inpatient Database. And the good news is that if you look at every patient who ever had a spleen injury, and this is just spleen, not liver. If you looked at every kid who had a spleen injury, they had a 95% of kids did not have their spleen taken out. The downside, though, is that in the small portion of patients who did have their spleen taken out, 72% of those kids never received a blood transfusion before they went to the OR. Some of them got blood, but they didn't get blood transfusion before they went. And part of this may have been that there was a historic dogma that you didn't want to give them blood and normalize their blood pressure until you had the bleeding stopped, or that you had surgical control of the bleeding. And that was a dogma that came out of Houston, Texas in the 1990s. We decided that we were going to look and to see how well that did. And we examined just the unstable patients. So not the whole, the whole database, but just the patients who had a Schotten index greater than 1, had blunt spleen injury, and were less than 18. And we excluded the patients who had other intra-abdominal injuries, or if they got transferred, because we wanted a really pure subset of patients who were unstable and showed up to the first trauma center. And this was written by one of my residents, Scott Eldridge, who hopefully will be a pediatric surgeon. We looked at the splenectomy rate as our primary outcome, and we looked at the timing of the blood transfusion, the hospital types, the sex of the patient, the age of the patient, the mechanism of injury, and then we did multivariate logistic regression to figure out what was driving the difference in splenectomy rates between the two types of centers. We found 516 patients in the database who met the criteria. We ended up excluding more than 4 times that many patients so that we got this very pure set of patients. And 27% of the patients of these hemodynamically unstable patients, 27% of them underwent splenectomy, 73% of them did not need their spleen taken out. What we found is that among the 27% who had a splenectomy, 26% of them never got blood transfusion before OR. When we looked at the difference between centers, we found that the splenectomy rate was twice as high at the adult centers. Even when we had, it was twice as high as the adult centers as in the pediatric centers. This is a chart that's too small to read, so I'll focus on the important part, which is that if you look at the risk of a blood transfusion leading to a splenectomy, this is about a 3-fold difference. Now that kind of makes sense, right? Because it seems like if you're bleeding enough to need blood, that you're probably more likely to need your spleen taken out. I will tell you that this number shouldn't be 2.9. This number should be 10 times. It should be a 40-fold difference that receiving a blood transfusion is a risk factor for splenectomy. But the number came out 3. It's a 3-fold difference. And the difference between pediatric trauma centers and the non-pediatric trauma centers was 2-fold, like we said. Well, it turns out once you risk adjust it, getting a blood transfusion is protective against having a splenectomy. And the statistically significant difference between the adult and the pediatric centers really decreases to about a 1.25 to 1.27 fold difference between adult and pediatric centers when you adjust for whether or not they got blood before surgery. So the increased risk of splenectomy at adult centers goes away, meaning that we think that it is the lack of a preoperative test of blood transfusion that is driving the high splenectomy rate. The other good news is that more than 70% of patients presenting with shock don't need their spleen taken out. And I think that we can fix this 26% of patients who undergo splenectomy, without a blood transfusion, simply by changing the education associated with it. So a few words about hypotension in children. So shock is not the same thing as hypotension, because in pediatric trauma, children can often be in shock and not be hypotensive. Hypotension is not the same thing as bleeding, because hypotensive children may not have even bled ever. And hypotension is not the same for everyone. And there's a lot of individual variability. So I'd like to go into all three of those statements so you understand them a little bit better. When we looked at the patients at the 10 centers that got transfused for shock, less than 50% of the patients who required early blood transfusion were hypotensive. They had these other signs that we talked about, the clinical signs of hypoperfusion, and that's what led to their blood transfusion. Now, the hypotensive group was older, so the teenagers were more likely to be hypotensive and get blood than the younger kids who were not hypotensive and still needed blood. So the median age was 15 in the hypotensive group versus 9. And so there's definitely a difference there where the younger kids are less likely to drop their blood pressure. The mean transfusion volume was similar between the two groups. And so these were patients who needed blood. They didn't just get blood and it was a mistake. They got blood because they needed blood. David Partridge is in Colorado, and he wrote this paper that really stuck with me for over years. And what he said is that hypotensive children are often not hypotensive during blood loss, due to blood loss. And when you look at the 0 to 5 kids, the really young kids that are hypotensive, 61% of the time it was due to head injury, and only a third of the time was the hypotension due to bleeding. And even when you get to the older kids, it really is about half the bleeding is due to, half of the hypotension is due to bleeding and half of it is due to other injuries. So you need to separate in your mind the relationship between hypotension and bleeding in children. When hypotension in children does occur, it is often a late and ominous sign in pediatric trauma. So it's not like they won't get hypotensive at the end. They will. Every pediatric patient before they die will get hypotensive. But a lot of times this is not when we want to identify that they've been in shock for the last 20 minutes. We want to identify it early. I'm going to digress for a minute and talk a little bit about adults. And because there's no equivalent data, there probably will never be equivalent data to this ever again in children. This is an adult study, and they were looking to validate a non-invasive monitor to trend individual response to hypotension. The physiologic data was unbelievable, and I read this paper. First of all, I couldn't believe that their institutional review board allowed it to be done. What they did is they took 42 men and women who are between the age of 19 and 36, and they did a stepwise removal of blood. They removed it at a third of a liter per session until they got down to 15 milliliters per kilogram of blood removal in the men and 13 mils per kilo of blood in the women. So they really were looking they took these volunteers and they bled them. And then the blood was reinfused at the end of the experiment. And so the way they did is they bled them, they plateaued, they bled them again, they plateaued, they bled them again. So kind of a stepwise, giving them a chance to adjust. I'm not sure that's how it happens after a car accident, but that's the way they did it. Only 32 of the patients completed the protocol, and 7 of the patients collapsed, and their collapse was basically they became unconscious, and their systolic blood pressure was less than 80. And so 6 of them never achieved the maximum blood loss, and they were resuscitated and got their blood back, and miraculously no one was injured in this study. But some data that came out was incredible, which is that the average patient who never developed symptoms and never got hypotensive less than 80, they were able to take out over 1 liter of blood. If you look at the 17% of patients who collapsed, they only had about 800 mils of blood that was taken out before they went to full cardiovascular collapse, unconscious, blood pressure less than 80. There are different types of people in this world, and there are people with low tolerance to blood loss and patients with high tolerance to blood loss. And they're using their device, they can calculate that there's a subset of patients who, when they lose 430 mils of blood, they are unconscious and hypotensive. Whereas there are other patients that we see all the time, some of which can lose 1.7 liters of blood before they actually get hypotensive or cardiovascular collapse. There are different types of patients. So if you have some people who can lose 1.5 liters of blood and other patients who can barely tolerate the amount of blood that's associated with blood donation, imagine if that second type of intolerant patient shows up in your emergency room with a spleen injury. They've lost 400 milliliters of blood and they look like they are dying. And the only way that you're going to know if they're still bleeding or if they've bled a tremendous amount is to give them a blood transfusion. You've got to give them a trial to see whether or not they are a patient who is intolerant to blood loss or whether they're just bleeding to death. Okay. Back to the children. So let's apply some of these lessons that we've learned to kids. And so what we find out in kids is that patients who fail to stabilize need an intervention. If you give them blood and they don't respond at all, they are bleeding faster than you are giving them blood, and they need an intervention. The intervention that you choose to do has to be based on your local resources. So if you have a hybrid IR suite, maybe you take them to that hybrid IR suite. But at most centers, that patient is going to go to the operating room. Even though we have cutoffs for operative failure, the reason that the algorithm says it's a failure of the algorithm to guide therapy and not a failure of non-operative management is because some of these patients are reaching 4 units of blood or 40 mils per kilogram very late. They're 2 days after injury, and now they've got 40 mils per kilo of blood, and you have to be able to take that into account. Now, what we found, though, is hypotension due to blood loss, whether your systolic blood pressure is less than 80, that is a significant risk of non-operative management. These patients who are super hypotensive are not good candidates for non-operative management. What we're really talking about these patients who have soft blood pressures. They have a blood pressure of 70 or 80, where some of them can really still be salvaged. We looked at the 113 patients who are hypotensive. So we talked about the 1,000 patients. We talked about the 300 patients who were in the recent bleeding. Now we're only going to talk about the 113 patients who are hypotensive when they show up in the emergency room. Now, of those 113 patients, 27 of them were non-responders. 10 died in the emergency room, and a lot of these were patients who had pre-hospital arrest. So they arrested pre-hospital. They come to the emergency room. They got blood. They got return of signs, but they could never get them stable enough to get them to the operating room. 17 non-responders basically went straight to the operating room. That gave us 75% of patients who responded to blood, and they responded long enough to actually get a CT scan. When we look at those 86 patients, those responders, it turns out that 72 of them had no angiography, and 71% of those actually required no surgery. Now, among those who were transient responders, there was another 27% who did have surgery. So it's not like this is a benign group. If they coming in hypotensive is a big deal, but it doesn't mean that every patient who comes in hypotensive has to have their spleen taken out or has to have their liver operated on. Overall, about 60 patients or 70% of patients avoided surgery simply by getting a blood transfusion and assessing the response. These are patients who were hypotensive. They're not just in shock. They're not just normotensive with delayed capillary refill. Their blood pressure is low, and still 70% of them don't need operations. So, the algorithm endpoint really says, all right, you get to this failure point, your options are angioembolization, surgery, or continued non-operative management. 91 patients reached this algorithm endpoint, and for those 91 patients, 62 of those underwent surgery, 19 of those underwent angio, and 10 had continued non-operative management. So even a small portion of patients, not very big, but a small portion of the patients who reach these endpoints can still be managed non-operatively. We put in the algorithm that a failure was that if you got more than 4 units of packed cells or 40 mils per kilo of blood, that was really a failure point. And that was based on a lot of expert opinion and one study by Lucas Neff, and it was a military study. So he, in the U.S. military, was taking care of a lot of injured children. So when you're at war, some kids are innocent bystanders and are hit. And what he found is that if you looked at the volume of blood given to kids versus mortality, that when you hit this 40 mils per kilo of blood products, that the sensitivity and specificity for dying in hospital over here or in the first 24 hours over here reaches a threshold. And so he used 40 mils per kilo as the cut point. And so it's not an unreasonable assumption, but I will tell you that when you look at 20 mils per kilo, you've still got 25-30% of your patients dying. And so even though we put that in the algorithm, after seeing the data in 1,000 patients, I have a slightly different perspective of that. We looked at, this is the unstable arm, we just looked at patients who were transfused within 24 hours. We looked at those who hit the cut point of 40 mils per kilogram and those that didn't. So among the patients who got transfused but didn't get 4 units or didn't get 40 mils per kilo, 68% of them had no surgery. But still, a lot of patients had operations, even though they were below the threshold. So this number may not be the right number. When we look at the patients who got more than 40 mils per kilo of blood, only 5 of 44 survived without having surgery. So 89% of patients who reach this threshold are gonna have surgery or going to die. That to me says this threshold was probably the wrong number. We probably need to lower this threshold. So I think when you get beyond 20 mils per kilo of blood products given to a child, you need to consider going to the operating room. Doesn't mean you have to go, but you just need to start thinking about it. If you hit 4 units or 40 mils per kilogram, that patient is almost certainly going to fail non-operative management. There's an 89% chance they're going to fail non-operative management. And once you get to that algorithm fail point, you have to decide what you're going to do with that patient. So let's talk about angioembolization in children. It's been recommended as an alternative to splenectomy for a long time, and there are multiple case studies describing angioembolization in children. And it does appear to have a role in severe blunt liver injury, and so there's almost certainly a role for it. This paper got published in JTACS, or the Journal of Trauma and Acute Care Surgery, less than a year ago, and it was by Miura in Japan using the Japanese registry. And they looked at 1,400 patients, and 22% of their patients underwent angio, and they had a very low complication rate. 0.6% complication rate is laudable. It's a very, very low complication rate, so they can do angio safely. But the thing about the study that struck me was that only 61% of the patients who went to angio even had a contrast extravasation on CT. And so it looks like almost 40% of patients weren't bleeding and they still went to angio. We looked at this study in comparison to our study. We had 1,007 patients who stabilized, not counting the ones who never had a shot at stabilization, and because we didn't feel like they'd be a candidate anyway. only 30 patients underwent angiography, so 3%. And among those 3%, half of them never got embolized. And so really, we saw our incidence was 1.6% undergoing embolization versus 22%. So very different perspective on angioembolization. I think, I think the bottom line is that angioembolization in kids is rarely needed. So when we looked at the ones we embolized, certainly there were more grade 4 injuries than any of the other injuries. This is 56%, not 56 patients. So grade 4s were the most common ones that we did it. The next question that was really important for us was this question about delayed bleeding. So if they stop bleeding, aren't they going to just start bleeding again, right? And this is more relevant to the spleen than to the liver, because that's what the thing that everyone fears. And that led us to make some recommendations regarding discharge timing and activity restrictions. And so I'll go into all three of those topics. So rebleeding after blunt liver spleen injury, and how common is it? Well, first of all, you need to know this is what our splenic injury histogram looks like. So we have a fair number of high-grade injuries. You've got 156 grade 3s, 100 grade 4s, and 40 grade 5s. So this is not just little minor nicks to the spleen. These are pretty big nicks to the spleen. And 73% of our patients had follow-up, which for an American study is pretty reasonable follow-up. A lot of these patients don't come back to the hospital. We knew from a study that was done by Holmes that a lot of patients, a lot of children who fail non-operative management fail very early. And in their study, the median time to failure for non-operative management was 3 hours. And 40% had failed by 4 hours, and by 24 hours, 87% had failed. And so these children who fail non-operative management do so very early. When we looked at our 1,000 patients, we found that they failed even earlier. So we divided it up into those that were failing for bleeding and those that were failing for other reasons. And failure for bleeding is really, really concentrated in most patients have failed by 3 hours from injury, not from arrival to the emergency room, 3 hours from injury. So if they're going to fail, they're going to fail early. These patients who failed for other reasons, they actually can fail a bit later. And so they're not necessarily in this 3 hour group. They're the ones that are going to the operating room at 24 hours or 36 hours post-injury. And I think it's really important when we start to make recommendations that we realize that they're two separate groups. There's the bleeding group, and then there's the kids who need surgery for other reasons. So with this information where we know that they're not going to bleed, that if they're going to bleed, they're going to bleed early, can we just send them home? And the algorithm, as you saw earlier, sends them home at 18 hours after injury. And there were numerous prospective studies that showed that early discharge was safe. And there were some rare cases of late bleeding that were reported. And so what we did was we looked to figure out who was at risk, who was this group of patients who needed surgery late. And the background of this is that even among the 1,000 patients, only 0.6% failed after 24 hours for all causes. So it's not like very many patients are going to fail. So candidates for early discharge, safe early discharge, are those with an isolated injury. So those who have a liver injury or a spleen injury, but not both. Patients who have a seatbelt mark or a handlebar mark, or I would argue any abdominal wall bruising, need to stay in the hospital for longer than 18 hours, because those patients may turn out to have peritonitis. They may turn out to have a hollow viscous injury that you need them in the hospital to discover. A lot of these patients don't get peritonitis until they're at least 24 hours out. In order to go home, they need to have a shock index less than 1.2. They need to be tolerating a regular diet, and they need to have minimal abdominal pain. If you look at this set of criteria, you've now defined the patients who can have early discharge. If you have a pancreatic injury, you're not going home. If you have multiple solid organ injuries, you need to stay in the hospital. If the CT scans show that you are bleeding, that you had contrast extravasation, those patients should not go home at 18 hours. And in all the patients who you do send home, they need to have a way back to the hospital, and they need to have standard discharge education as to what criteria they need in order to come back. All right. Can some of these patients not be admitted at all? Is it possible that some of these minor injuries don't even need to be in the hospital? We looked at grade 1 and grade 2 injuries, And we were able to define a set of criteria where patients can simply go home. So if they don't have abdominal wall bruising, they don't have limited access to care, and they are a grade 1 or grade 2, they can go home. But they have to have a shock index less than 1.2. They have to be tolerating a regular diet. They're just like the other patients. The difference is that you're sending them home from the emergency room. Okay. All right. And then we also use that same data to support this sending them home from the emergency room, saying, look, if they haven't failed by 3 hours, they're not going to fail for bleeding. All right. What about bed rest? There's a lot of assumptions that bed rest is part of managing non-operative management in liver and spleen injury, but it turns out there's actually no study that has ever supported bed rest as treatment for a liver or spleen injury. And there's one adult study that showed that there was no difference. It was a renal study that we did that showed that bed rest is not necessary for a retroperitoneal kidney injury. There are 5 prospective studies showing that an abbreviated period of bed rest, so a very short period of bed rest, was fine. And we think that you can save about 36,000, 37,000 hospital days if you simply eliminate bed rest and eliminate activity, eliminate hospitalization of these patients. And so, what we were able to say is that if you limit their activity to no sports and keeping one foot on the ground at all times, and then no wheeled toys, so they can't be on a bike or a skateboard, we feel like you can safely let those patients go home from the hospital and even go back to school. The basis of that was that in the United States, a lot of patients, the doctor tells the patients to do something, but they don't do it. And so we actually asked the families whether or not they were compliant with their activity restrictions. And about 76% of patients said that they followed the doctor's orders, but there was actually a subset, about 13% of patients, who basically said, yeah, I did not restrict the activity on my kids. And they were willing to admit that. And so we did a planned secondary analysis thinking that there'd be some people who didn't do it. And we looked to see whether or not they returned to the emergency room or got readmitted, and if there was any difference between those who had activity restrictions and those who didn't follow the activity restrictions. There was no difference. So no patient bled after discharge, whether they followed activity restrictions or not. And so even though we still recommend them, we don't think that activity restriction is relevant to whether or not that patient's going to rebleed. When we looked at length of stay, the old guideline, which is the American Pediatric Surgery Association guideline, said that they needed to be in the hospital for grade +1 in days. The Atomic guideline said you can go home in 18 hours. The difference in days between the two groups was striking, so we saved about 600 days of hospitalization just in these patients. And this is not all the patients. These are just the patients with isolated injuries. We saved even more in the patients who had multiple injuries, but the difference, this is a 44% difference. This difference is much more striking if you just look at the patients who have an isolated liver or an isolated spleen. All right. Additional clinical questions. We use 7.0 as a transfusion threshold. There was a lot of studies to support this, and it turns out that was totally safe and totally fine. We wanted to try and figure out what symptoms should prompt reevaluation after discharge. We included all of the same findings that we associated with shock at initial admission. We also added black tarry stools. The only patient out of the 1,000 patients, the only patient who rebled was one liver injury who had developed hemophilia and basically showed back up with a GI bleed that basically stopped on its own. We didn't even have to reoperate on that. We do know that delayed bleeds have occurred. They're in the literature. I've looked at this literature in detail. I think a lot of them are actually patients who never stopped bleeding to begin with. I think that the one patient who rebled after 32 days is not a typical patient. I think something happened to that patient. It's hard for me to imagine that we had 500 patients that we followed and none of them rebled, but this one patient, bled to death after a month. That just doesn't seem consistent with what we find. We recommended no routine reimaging, and that had actually been in place for 20 years. And a lot of people say, oh, you need to reimage to find pseudocyst, and there's good studies that show that most pseudocysts that have been reported to trauma are probably congenital, if you really look at the pathology. And then the question about pseudoaneurysms was, keeps coming up. There was one study from Arizona, not from Phoenix, but from Tucson, Arizona, which is about 100 miles away, where they had patients with high-grade injuries who bled. And the problem with that pseudoaneurysm study is that we know that a lot of patients develop pseudoaneurysms within the parenchyma of the liver or within the parenchyma of the spleen. But the natural history of those pseudoaneurysms is that they spontaneously thrombose. They don't need angioembolization, they don't need follow-up imaging, they don't need anything, they just take care of themselves. When we talk about patients who have pseudoaneurysms of the hepatic artery or of the splenic artery, not in the parenchyma, I think those are a very different animal. I think that those patients need angioembolization. That is not an injury of the spleen, that is an injury of the splenic artery. When you look at the study that everyone quotes, if you see the angiography that they're doing here, this is their pseudoaneurysm. This is not in the liver. This pseudoaneurysm is in the hepatic artery going to the liver. This is another one they embolize. This one's a prophylactic embolization. This is what happens routinely is they see this pseudoaneurysm and they embolize it. I think a lot of these would take care of themselves if you didn't embolize them. In our study, we did not do any routine reimaging. 6% of patients got reimaged for symptoms. It made a difference in one patient who was found to have a bowel obstruction, and really there's no utility in doing that. Fast examination, I won't talk about in too much detail because we're running out of time, but basically if you have a negative FAST, you're unlikely to fail. And what can we do to lower the rates of splenectomy? I think the most important thing that we can do is that we can institute an algorithmic approach. We can say, all right, there's a guideline here. Let's use the guideline. It will tell us when patients have failed. It'll tell us when it's safe to still continue with non-operative management. When we looked at those patients, and this chart is in the Journal of Pediatric Surgery. So for those of you who get JPS, it's really interesting. We really looked at who failed for what reason and who got angio for what reason, and there are a lot of injuries in here that are not liver and spleen injuries. We have patients who have diaphragmatic injuries, bladder ruptures. We have a lot of hollow viscous injuries, and we have a lot of patients who have mesenteric bleeding. There are a lot of reasons besides the liver and the spleen that do need surgery that are not directly related. When we look at the causes of death in this thousands of patients, what you see is that bleeding was only a cause of death in 5 patients out of 1,000 patients. Okay, it may have been that. That's an underestimate because the reality is that there's also these patients who bled to death before they got to the hospital. Those patients who never made it into the study and got added retrospectively. But among those patients who transiently respond enough to get a CT scan, very few of them bleed to death. Neurologic injury is really the cause of death for most of these kids, and that included traumatic brain injury and internal decapitation. So in summary, management by hemodynamic status or response to blood, not by grade of injury, is the way we need to be managing these patients. Stability can be defined by a reasonable set of clinical criteria, including blood pressure, heart rate, SIPA, pallor, capillary refill time, and skin temperature. We need to consider giving a child a blood transfusion prior to the decision to go to surgery. Transfusions to threshold of 7 is appropriate for non-operative management. When non-operative management fails, it fails early. Discharge before 24 hours is safe in appropriate patients as long as you use the safeguards that I've defined. Activity restrictions, we don't know if it makes a difference, but we do them. And then routine follow-up imaging doesn't seem to make a difference. So I'll follow up with my 15-year-old patients who was dragged under the car, who had that bad injury. The bleeding stopped. He developed abdominal distension and started having fevers. He got an ERCP, and he basically had a pretty bad bile duct injury. You can see the bile duct here on the ERCP. This is the liver injury about a week later. It goes all the way through the liver. This is him after it failed. He went to the operating room for a laparoscopy and a washout on post-injury day 12. So he technically failed non-operative management, but I will tell you that I would much rather wash out a biloma and wash out blood than to operate on a laceration that clearly split the liver in half and have to manage that bleeding. Thank you. I'll take any questions.